My name is Professor Brian Saunders. I'm a consultant gastroenterologist at St Mark's Hospital in London and Professor of Endoscopy Practice at Imperial College London. Now, I've had experience of using the ENDOCUFF for the last 8 years, and the ENDOCUFF Vision, I've performed probably over 4,000 procedures using it. So I have a lot of experience at using the device, and I want to try and get that across to you in this teaching video.
Good morning. My name is Andrea. It's a pleasure for me to be here in this ENDOCUFF session at Olympus this morning. I'm a gastroenterologist in a clinic in the northern part of Germany, in Münster. I'm the head of the clinic. I'm a specialized endoscopist, and we're using in the clinic since a couple of years the ENDOCUFF, now the ENDOCUFF Vision, and we'll talk about a little bit what the advantages of ENDOCUFF is also for the daily routine in our colonoscopy patients. What is our goal? Our goal is to prevent colon cancer. So when we do screening or surveillance colonoscopies, there has been a fair amount of work on finding techniques and finding new solutions to get a better results on our measure of quality. What is our measure of quality? Our measure of quality is here the normal detection rate, and the ENDOCUFF Vision has been shown to maximize this ADR, so the adenoma detection rate as well as the polyp detection rates. It is for our daily work in experienced colonoscopists. I think it's something that enhances our results and makes our works on our patients to find or to prevent colon cancer. It's something that is for sure positive for us. We're gonna show you today a little bit how to handle the ENDOCUFF Vision. First of all, also how to place it on the scope. You can see here in front of me that we have different ENDOCUFF Vision types. There are different colors. What do the colors mean? The colors, they mean nothing else than different sizes. So you can place them on different types of colonoscopes. So you can also use it for example, for a colonoscope that you use for pediatric patients. And so you have to fit for the right scope, you fit the right color. I show you now how to place an ENDOCUFF Vision on the endoscope. You'll see that it's packed in a single pack, and you actually open it and don't take it out yet. You take the endoscope and you place it, the tip of the endoscope, you place inside the ENDOCUFF Vision. You then take it out, and this is very important now to push it back all the way that when you have the endoscopic image, you don't see any border and any rim of the ENDOCUFF Vision. Then you're sure that it's placed right and is fixed on the colonoscope.
One of the things that people are always very worried about with the cuff is that it'll come off, it'll detach. And when you're busy in the endoscopy environment, it's very easy to forget to push the endocuff right onto the tip of the endoscope. You should see no endocuff at all at the end. If you can see endocuff, there is a risk that it's not securely enough on the tip and it might detach. And you have to be particularly careful in patients who have very strong anal sphincter or who are relatively lightly sedated. So always double check. The endoscopist should do this before you insert the scope. You can see no endocuff. With the endocuff on the endoscope, I lay the endoscope out just on the patient trolley and perform a gentle rectal examination with plenty of lubrication. And then as I take the index finger out from doing the rectal examination, the digital rectal examination, I insert the endocuff, the scope with the endocuff on the end alongside, so that you guide the instrument in through the center of the anal canal. The endocuff does increase the diameter of the tip of the endoscope, and it is slightly ridged. So this is potentially an uncomfortable moment for the patient. You can really reduce that by good lubrication and by doing that technique of guiding the tip of the colonoscope as the index finger is withdrawn. The anal canal varies in length quite considerably.
Yeah, I don't have a lot of comments to do on that. I do it actually very similar. One question I would have, Brian, do you put the lubrificant on the scope, or is it enough for you to do the digital examination with the lubrificant and then you just wetten the scope with water? That's what I do. I don't put any lubrificant additionally on the scope. I do it when I do the rectal examination, and then I wetten the scope with water, and usually that's more than enough to get a gentle insert in the anal canal.
Yeah, I mean, you'll have lubricated doing with the finger doing the digital rectal examination, so it's relatively straightforward then just to put the ENDOCUFF scope over the top. It's easy in some patients if they're older or they have a slightly weaker anal sphincter. In younger patients with high anal tone, you have to be quite careful not to cause discomfort at that point. So the cuff is also useful during the insertion phase of the procedure. And of course, because the arms of the cuff are out of the field of view, you can't really see what it's doing, but it is actually a great assistance during insertion. Nowadays, with the washing pump at the end, we can use water very freely. And I think most colonoscopists have moved over to a water exchange or water immersion technique, particularly for insertion through the sigmoid. But what the cuff does is that as you gradually fill the sigmoid with water and creep forward using very small lateral or up and down movements to find the lumen, the cuff helps to keep the lumen of the mucosa in the sigmoid away from the tip of the scope, so that you can still see and locate where the lumen is. So here, as we go through the sigmoid, I'm infusing water continuously, and every now and again we're pausing, we're suctioning any gas pockets, and I'm pulling back slightly at times just to help straighten the sigmoid. And with that, you can often keep the sigmoid relatively straight with easy passage into the descending colon, and fairly rapidly pass along the left side of the bowel. You can't see what the arms are doing, but they are helping just to concertina the sigmoid back and straighten the sigmoid to ease passage. And of course, if you can keep a straight sigmoid, then the rest of the procedure is relatively straightforward. So Andrea, are you using a similar type of technique? What's your experience going through the sigmoid?
Yeah, that was actually a very nice demonstration how to straighten the sigmoid. I think the water injection technique, especially since we have the endo water jet, is something that we really use in almost all the patients. Maybe on this part also, I'm sure that you have also a lot of trainee and young endoscopists that work with you. Are they taught really to use the endo water jet already in their training program, or is it something that should be done by really experienced endoscopists?
No, the trainees, they're taught insertion with water. In fact, it makes the insertion easier, and they find it quite easy to adapt to. Do you turn the carbon dioxide off? Do you turn it off? I personally don't, but I try to absolutely minimize the use of any carbon dioxide. We don't use room air anymore for obvious reasons. But I don't actually turn the carbon dioxide off, but our trainees adapt to it very quickly. The Buscopan question, the reason that people are worried about Buscopan is they perceive that it might make the colon longer or sort of but the brilliant thing with the cuff is that the cuff allows you to straighten any degree of looping. So I'm not concerned about that. I'd rather have the anti-spasm properties and be able to steer accurately through the sigmoid. So that's why I give Buscopan early on in the procedure. With the cuff on, even if the proximal colon is a bit longer than it would have been normally, you can control that with the cuff and straightening maneuvers. So in this case, there is an obvious N loop you can see on the scope guide imager. And the advantage with the cuff is that it's relatively easy to straighten loops, because as we pull back the arms of the cuff engage at the tip and anchor the tip, giving you more purchase to allow torque and withdrawal to really straighten that loop. And then keeping the torque once you start to push forward, force is transmitted with the straight scope through the tip. The arms then detach from the bowel wall, will lie at the side of the scope, and you can then progress and move forward.
Once you do that, and you can see that on the scope guide, do you rotate the scope or is it a straight maneuver?
It's a combination of clockwise twist in that end loop and withdrawal, and then at the point of reinsertion, once the scope is straight, keeping a slight clockwise torque. That transmits force through the shaft of the endoscope towards the tip, and allows forward movement of the tip. But often at several different points during the colonoscopy, there's a slight degree of looping, but it's much easier to control loops with the cuff. If I have a patient who I know has got a really long and mobile colon, I will always use the cuff because it's so much easier to control the looping and straighten the instrument. And in fact, patients who previously have needed double balloon colonoscopy, now I can scope with the cuff because I can control those loops going forward. So in this situation, or if you look at the scope guide imager, you can see we've passed around to the proximal transverse colon, but there's a little bit of looping occurring, and we're trying to get around the hepatic flexure to pass down into the ascending. Now, at this point, as we push forward, there's a deep transverse looping, but if we get up to the main bend and then engage the endocuff, we can pull back to open up the fold and then pass around the hepatic flexure down into the ascending colon. And there's the cecum coming into view with that typical question mark appearance on the image of view and the appendix orifice.
Brian, can I ask you, this is often the situation where we ask our assistants to put some pressure from outside so we can do exactly what you just did. In your experience, does also the application of the endocuff vision minimizes the pressure we need from outside? So are you more, do you need as often the assistance as you used to do without the endocuff vision?
Yeah, so it's certainly my impression that the number of times you need to position change or use abdominal pressure is significantly reduced.
Yeah, I can absolutely. It's actually also my experience. I think it's a very relative point.
So Andrea, we've got to the cecum. Do you go into the terminal ileum in every single patient?
Yes, yes. For two reasons. First of all, I think it's very important. I do a lot of trainee. I have a lot of trainee in my clinic, and the only way to learn it when you really need it, that you do it on a routine basis. The second point is that we have a pretty big IBD cohort of patients. So as you know, that's actually mandatory that we look at the terminal ileum. So it's I really try to teach that we do it in every colonoscopy, yes.
So with the cuff, more difficult, less difficult?
What I would say, it is, of course, one of the most challenging things when you learn to do a colonoscopy to insert the terminal ileum. I think that the techniques and the tricks that you learn in a colonoscopy without the endocuff, if you use that then with the endocuff, actually I don't see any problems with the endocuff. So what we need to do is we have to be sure where is the entrance of the terminal ileum. We have to, and this I think, and this is the first thing I learned from my first endoscopy teacher, never try to insert the terminal ileum when you really had a lot of air, a lot of CO2 in the cecum, because of course you straighten the cecum and then the tension on the cecal valve is too high. So the first thing I always teach is go in the cecum, take the air out, take the CO2 out, be sure where you are. And if you're not sure, go back a little bit and look at really the point where you want to go in. And I personally, in my experience with the endocuff, is that with the branches, you can really go on one of the rims of the lips of the sacral valve, and you can kind of open it up for you. In my experience, after you do it, of course, in a certain amount of patient, I don't encounter more problems than without. Maybe if you know how to do it, it's even something that can help you go inside the terminal island. I don't know what your experience about it is.
Yeah, initially I thought it was slightly more difficult to get into the terminal ileum. Certainly slightly more difficult than if you have a cap, a plastic cap. But you can always get into the terminal ileum if you want to. What is more difficult is deep terminal ileal intubation. But we would want to get into the terminal ileum to photo document, to practice it for when you really need it. So people are often worried about whether or not you can retroflex with the cuff on. And the answer is almost always you can, obviously in the rectum, but also in the right colon. So here, this is using a pediatric scope. I've retroflexed in the cecum. And then in that retroflex position, you can actually pull right back to the hepatic flexure. And you get a very unique view of the proximal colon by doing that. The cuff, the arms of the cuff, as you retroflex, fold back alongside the tip of the scope, so they're not impeding anything or causing any problem. But like all retroflexion, if for some reason it's not retroflexing easier, never use force. It is potentially dangerous, any form of retroflexion. So if it's going easily, then continue. But the cuff itself does not impede the ability to retroflex. So here we are just coming back from the cecum, and you can see clearly that there's a small polyp.
What do you feel? What do you think are the most striking advantages in therapeutic colonoscopy using the ENDOCUFF?
So the tip stability provides you with optimal access, which means that you can deliver the therapy more effectively and in a quicker time and in a more controlled way. So one of the big advantages with the ENDOCUFF is coming back through the proximal colon, where you can use the scope to push the cuff into the side wall and open up the inside bend of folds whilst maintaining visualization. And you'll see intermittently the cuff arms coming into the field of view when they deploy to hold the fold back. And you can move backwards and forwards, but generally the amount of backwards and forwards movement is reduced. Therefore, the withdrawal is much smoother and more efficient.
Talking about efficiency, are you also faster in the withdrawal using the ENDOCUFF?
Yes, significantly faster. In fact, sometimes, almost bang on 6 minutes. Whereas before, if you don't use the cuff, we're up at around 10 to 12 minutes to do a good examination. The cuff just gives you such a good view at various different times during the procedure that your withdrawal is much more progressive. It's sort of slower and controlled and more progressive, but you're not having to go constantly backwards and forwards and fight with the fold the way you are if you haven't got the device on the tip. So this is where the cuff really has a very obvious advantage coming back through the left colon. The left colon is a little bit narrower than the right colon. So the arms of the cuff can deploy completely to open out the folds and allow that very controlled withdrawal, keeping the tip of the scope pretty much in the center of the lumen. And then if the cuff works in tandem with the washing pump, you can wash a little and clear any debris. And just very gentle, slight backward movements, just giving that panoramic view of the entire sigmoid, really speeds the withdrawal process. Without the cuff, that would be collapsed. The folds would be very prominent and difficult to see around, and very easy to miss polyps on the proximal side of folds. With the cuff, it's opened out. It's much easier and much more controlled. And then if you do see a polyp, it's easier to stop, have a stable position and remove the polyp.
We all thought we were afraid of missing polyps in the right colon, and the ENDOCUFF was good to defold the folds in the right colon. If you see this video, I think ENDOCUFF is in the left colon as important as it is in the right colon. And one thing that you can see very good in this video is not only how it keeps it open and you can see behind the folds, but the scope is always in the middle of the colon. And I think this is something that is extremely important, and you can really do that with the ENDOCUFF. I think that's a very beautiful video to show that.
So here we're back in the sigmoid colon, and I've encountered quite a large polyp in the mid-sigmoid, which is quite an unstable place because obviously the sigmoid colon is free on its mesentery. But with the cuff, we anchor the position very nicely. You can just see the arms of the cuff deploying there, allowing injection and then subsequently snaring, snare positioning and diathermy. And what's nice about the cuff, because you have that stable position, we're much more confident at this point of cutting, knowing that if there's a problem with the polypectomy, I can deal with it very quickly and promptly. And the main issue here would be if there was sudden arterial bleeding after the resection, in which case we've got stable access to put clips on or use diathermy. In this particular instance, I haven't quite removed all of the polyp. There's a tiny bit on the edge, but because we've got that stable position, it's very, very easy and quick just to redeploy the snare, capture that final piece of polyp, remove it, and then secure the position with the defect with clips to ensure there's no delayed bleeding. But all because of that stable access onto the polypectomy base.
Good to show that like this, I think, Brian, because you can see that even if you have a problem during the polypectomy, you stay pretty stable there and you still have the chance. I mean, this is not perfect for a polypectomy, I agree, but this is perfect for the position and you don't lose your position. Imagine you would have done it without, the polypectomy is not total and then you have to find your position. You stay there, and I think that's a great advantage of the ENDOCUFF, what you just showed.
So Andrea, we're back in the rectum now. What's your standard approach to examining the rectum?
Well, actually, we used to always put a cap on the endoscope to examine the lower rectum and the anal canal. We don't do that anymore since we routinely use the ENDOCUFF, because it really has the advantage to really open it up and to give us almost in every patient a good view to the lower rectum. So the chance of missing polyps in that region of the colon, I think it's not anymore what we fear.
Generally, I would do both. It's perfectly straightforward to retroflex with the cuff on in the vast majority of rectums.
Brian is actually the author of the evidence of ENDOCUFF. I think we're doing evidence-based medicine, and I think that nowadays that's what we are supposed to do. And I think that now for the ENDOCUFF, we have a fair amount of good evidence to show that also in randomized studies it shows advantages with the advantages we talked about. So it's not just our feeling of experienced endoscopists to use it, but it's really also something that is evidence-based by now. I think that's a very important point.
Yeah, so recent studies have shown that the cuff makes the procedure more efficient in terms of time and significant pathology detected and treated and removed. And this, is going to be really impactful, particularly in a COVID era when we really need to make sure that we direct our colonoscopy service to patients who most need it, and to, when we perform colonoscopy, to be most effective in delivering cancer prevention, which is what it's really all about.